السلام عليكم ورحمة الله وبركاته. صباحكم الله بالخير جميعا. Thank you for coming for the third day. I think the third day is one of the most exciting days for me. I think it's directed mostly to the backbone of all NICUs. Where most of the topics today is related to nursing care. Nursing care is really what makes or breaks any NICU. So we got the scientific sessions today and talks mostly about improving quality of nursing care. We got local speakers with a lot of expertise, and we have international speakers as well. And I would like to introduce our moderator for our first session, Dr. Mohammed Al-Hassoun. Dr. Mohammed Al-Hassoun is an associate professor in University of Qasim. He's a consultant neonatologist in Jamiat Al-Qasim. And without further ado, please, you can introduce everybody else. Thank you very much.
So, good morning, everyone. As Dr. Talal mentioned, it's an excited topics for today. As you know, without qualified and competent nurses, an ICU cannot be built up. So please just let me welcome Ms. Manal Mohammed Al-Amoudi. She is having expertise in the NICU. She is certified NRB instructor, and she is dedicated to training healthcare professionals in life-saving newborn resuscitation techniques. So please welcome me to talk about the first topic of today, which is eclampsia prevention in the NICUs. So please join us.
معلش الكمبيوتر ما حيكون هنا حاعتمد على الشاشة. Yes, I need our computer. No, this is enough, but I need our computer. They will be connected. لا راح نشبك احنا الكمبيوتر. في مجال yes ما في مجال. اوكي طيب هذا كيف انا اقلب وين هذا اللي فرونت هذا قدام هذا ورا. طيب بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. Good morning everyone. My name is Manal Al-Amoudi. It's my pleasure to present it today about a small topic about prevention eclampsia in NICU. But before start, just let me to ask you, do you think we can reach to zero eclampsia in NICU? Yes? Agree? Okay, whatever you are thinking, to see later. Today I have just around 20 minutes to present my topic about a huge a huge topic of prevention of eclampsia. According for evidence, to reach or to achieve this prevent of eclampsia, we should not depend just on new technology. We should depend on strict, constant, and uncompromised application of care bundles. The key point is to focus on our practice, not on just paperwork. So just to say thank you for Sister Isra from Al Yamama Hospital for these nice pictures. It's clear for us she is doing her best and adheres for insertion bundle. Because I think she's believed that every line and every touch and every second, it is a fight against eclampsia. Eclampsia, it is look small words and easy to say eclampsia, but actually behind of this word, there is a hard situation and struggling life for baby and also for family, even for us. Central line, it is intravascular catheter that terminated or close to heart through the great vessels that we are infusing or taking some blood. CLAPSI, it is catheter line blood, associated blood strain infection. Here, again, this is the photo for this CLAPSI. Impacts of CLAPSI. There is many impacts of CLAPSI. It is starting from prolonged hospitalization and can be end by death. So prolonged hospitalization can also increasing health costs, increasing the rate of morbidity and mortality, and maybe can be also long-term issue health like neurodevelopmental issue or delay. Here some risk for CLAPSI, or we think all our newborn has risk for this CLAPSI, because I think there is overlaps causes for this baby, because most of or all of our baby has immature immune system, and most of them maybe are premature or low birth weight, and also fragile skin. All these causes can be increasing high risk to acquire this infection and decrease ability to fight the organism. Also, longer hospitalizing stay. This is can exposure for baby to the pathogens. Frequent also handling even by parents, or invasive our device like UVC and Becline. Here some rates of CLAPSI. Globally, its rate range between 0.5 to 3 per 1,000 catheter. So we can keep in our mind, the lower the birth weight can be, the higher the risk. In Saudi Arabia, by MOH, neonatal CLAPSI rate was 3.7 per 1,000 catheter days. The target, according for CDC, ideal, it will be less than 1 per 1,000. Kingdom try or to seeking to reach or to decrease the CLAPSI rate by 50%, and this it will be over 3 years, already starting on 2024 and will be end on 2026, and the aim to reducing up to 1.8. I think this is the most important slide here. It is the prevention central line called bundles. I can also call twins, because we cannot work on one bundle. It should working together. We cannot working separated. Central line insertion bundle, it is starting by most also important step. It is hand hygiene. We cannot go to another step or on another point without hand hygiene. I will not go through details about hand hygiene, like types or 5 moment, but we should keep in our mind all points or steps in this bundle. It is all more, it is important to prevent CLAPSI. Like maximum barrier precaution, either for healthcare provider or baby, by using sterile drip or sterile PPE. Chlorhexidine skin antisepsis, it is the one recommended to using, and we should keep also aware about some side effect for some baby, like preterm or low birth weight. Optimal catheter selection for our baby, it is individuals. Ultrasound, it is rare in our unit, but can be in adult or elder baby. Other bundle, it is like save or restore. Our effort we are applying in searching bundle, and again, we cannot start without hand hygiene, especially aseptic technique. We should also delay review for needed for this catheter and we should remove as long as possible if the baby he doesn't need it because of high risk of eclampsia. Proper dressing choice, we should also care about type of dressing. It should be transparent and to be more clear to monitoring for any signs of infection. Frequency to change of this dressing, according for policy, it should be every 7 days, unless there any causes to change, like solid or dirty. And proper replacement of administrative set. Here there is some points I can mention as a point. For this, it's different according for what we are infusing through this set. Some we can change every 3 days, and some we can change every 24 hours, like TPN, and if blood, we can change after finish immediately. Here's some practical recommendation for eclampsia prevention in preterm infant. I use this recommendation for antiseptic because there's some limitation or some side effects to use this. Chlorhexidine, we are facing some problem, especially with extreme preterm or low birth weight. Maybe they will affected for the baby like chemical burn. And there is alternative use like bufidine, also has some side effect like thyroid dysfunction. But there is a recommendation to decrease this side effect after using. Maybe we can use less concentration of chlorhexidine and with aqua instead of alcohol. In our hospital, we are follow this recommendation by using sterile saline wipe after dry disinfected. We should respect the contact time of disinfected. This is example of chemical burn. I think it's hard and painful, and no need to put baby in this situation. This is another topic, another situation. It's related for mispractice for health care provider because they are using big or not proper dressing to fixing the umbilical. Actually, umbilical not needed to fixing, just needed for using holder or bridge, no needed to cover. If we are using improper dressing, we can cause like this damage of skin. And this is also cause of infection for the baby. I mentioned some evidence-based practical to reduce eclampsia in NICU. A multi-center study reported the UVC position. According for this study, they found low position of UVC has high risk of eclampsia compared with high position of UVC. If we are unavoidable, we should not keep more than 48 hours because can cause eclampsia if it is more than 7 days. So better to remove and insert instead of by big line. Here, material selection. I see this topic also nice to mention because maybe some they don't know about there's different material can affect it for eclampsia. Central venous catheter typically made from either silicone or polyurethane. Silicone catheter, it is most chosen for long term, and it is distinguished by softness and flexibility and biocompatibility. Also, there is another advantage and disadvantage. I will try memorize some. Advantage of silicone, as we said, it is flexible or softness, and this is suitable for long-term use. It can be comfortable for the baby, less injury for feces, and less for infection because of biocompatibility. One of side disadvantage, and it is rare, rupture or disconnector, and for the doctor, maybe it is difficult to control or using to insert this catheter. And for choosing, it's depend on the doctor experience or availability. Okay, here another type of central line, but this time according for numbers of lumen. We have many types, as we know, single lumen or double or triple. Single lumen is the preferred, or it is the safe recommended because it is single. So that means less birth, less needed to manipulate it, and less this lead to less infection. Double lumen, it is only if clinically essential and need. Like if we have incompatible medication or IV fluid. So here we are needed to use it, and we can keep in mind risk it will be increased with any additional lumen. So triple lumen, it is should or better to avoid it because of risk for manipulated, disinfected, but sometimes we are needed according for situation, and if we are we can unavoidable try to use maximum disinfected for this. And we can also remember if the catheter is large in size, this can cause some chemical complication like fecal damage or thrombosis. Closed system in central line to prevent eclampsia. As a name, closed system. Closed system, it's recommended, and closed, that means we are clamped and covered by some sterile cap or disinfected cap. It helps us to minimize exposure to air or contamination. What's the mean or what the idea of closed system? It is to maintaining pathway of infusion pathway, starting from infusion fluid or medication through tubes, through hub, ending by lumen. And we can also make sure it is covering and securing nicely. This part or connector, I saw it's very nice to use in closed system because it helps to prevent also eclampsia because has valve called positive pressure valve. This valve can reduce flow back the blood and accumulate it in the hub, and this is source of infection. This also can help to needed to disconnect of tubes or after flush cannot allow the blood to return to the tubes. So it is very helpful and and it is really minimize the infection. Our baby, he asks you now if you have any suggestion to reduce this eclampsia. From my side, yes, I have some recommendation. Full adherence to insertion and maintenance bundle, ongoing training and competency assessment of staff, adopt local protocol, align with CDC, WHO, and MOH guide, aim for local benchmark. Again, I will ask same question. Do you think we can reach to zero eclampsia in NICU? Okay, yes, just you, my colleague, yes, okay, yes, sure.
You cannot have zero forever.
I respect your opinion. Okay, sure, yes, but it's difficult. I agree with you. We can make it reality for every newborn if we work together. It can be preventable. Nothing is impossible. Thank you. شكرا.
Thank you, Manal, for this wonderful talk and insightful presentation. I do believe that we have plenty of 5 minutes if we have any comments from the audience or any questions. Yes, Dr. Amar, please.
Thank you so much. Fantastic presentation. I always say that CLABSI is the best indicator for any hospital performance. This is number one. If you want to go into a hospital and know about their performance, just ask about CLABSI rates. This is number one. Now regarding the single versus double versus triple lumen, in neonates, single is better. Why? لأنه يا جماعة, when you have a 3 French single, the internal diameter is bigger than 4 French double or 5 French triple. The French is the external diameter, it's not the internal diameter. تمام? So the more lumens you are adding, the smaller the internal diameter is. And the more likely to develop thrombosis later on. And the more likely for CLABSI. A baby with triple lumen peak has triple the chance of developing CLABSI. So always do not opt out from inserting double and triple lumen unless they are really, really needed. Single are better. Yes. The thrombosis is less. The mechanical problems are less. Yes. The infection rate is less. The internal diameter is bigger, and so on. Polyurethane versus silicone, I think mechanical problems with polyurethane are less. So silicone is more likely to be dislodged or cut. Yes. And then the last thing is about if you're using double lumen, you actually need to run something in both lumens always. Do not saline lock or hep lock one of the lumens because you're inducing thrombosis. And if one lumen is blocked, the line should be taken out. Yes. Do not leave the line in while one lumen of the double or the triple is blocked. You have to take it out. So that's why I always prefer single lumen. حتى في UVC, I prefer single lumen. In a 500 grammer baby, when you put a double lumen UVC, with a TFI of 80 or 100 in the first day, the actual rate running in the infusion pump is gonna be overall 1 point something or 2 mils per hour. Now, you need to split this number into 2 lumens. You end up running in 1 lumen something like point something. And if you're running this slow rates, thrombosis goes up and problems happen. Again, do not put double lumen unless it's strongly indicated. So baby in multiple inotropes or baby is hemodynamically unstable and so on, sure. But just for a routine UVC or a routine pick, stay away from the double and triple lumen. Thank you.
Thank you, Dr. Omar. Thank you very much. Great comments. Yes, Prof. Abdurrahman.
Yes, we need to prevent CLABSI, but we don't want to damage the skin. The 4 cases he showed to us is really depressing. How we can avoid it? This is by the use of chlorhexidine and iodine, صح? Chlorhexidine. So how we can avoid it? We don't want to prevent CLABSI at the same time we burn the skin that
yes,
much.
Yes, Doctor. We are also tries to searching for alternative, but by infection control or by MOH, when we are consulted with them, they strongly recommended for chlorhexidine. But there is less concentrate, but still there is risk for this side effect. In our hospital, we are using, after using chlorhexidine, let to dry for 30 to 1 minute. After that, we can use sterile normal saline to wipe the chlorhexidine as trying to help to avoid this side effect.
And the chlorhexidine في فترة من الفترات قلنا it is neurotoxic, but it will absorb from the skin in premature baby and cause more harm. Maybe simple suggestion before we said the baby still is fresh, not yet colonized with a lot of bugs. Maybe normal saline is enough, خاصة when you start to put UV line or central line.
When I prepared this presentation, I tried to find anything new than bundles to help us to prevent eclampsia. But all study they are supporting.
تعالي هنا يا بنتي انت جالسه بحلك كفين انت بقول هيريو
بس اضيف النقطة هذه.
هذه تعالي عشان نسمعها.
Actually, when I prepare this presentation, honestly, I try my best to find anything new to add. But actually, I'm searching, all study, they supporting same bundles. I'm searching for chlorhexidine. Any study just give me any new idea, but again, they are directed me to this bundle. But according to doctor, for study, recommended for chlorhexidine to prevent eclampsia. Yeah, but most of the time it is not available. This less concentrate. 2% with 70 alcohol. This is, but now we have with aqua.
2%.
Yes, 2%.
2% for
Yes,
preterm
2%.
babies is too much. I'm sorry.
Okay, but according for study, they said if you have extreme preterm or low birth weight, we can use less concentrated.
Yes, we have to use less than 2% in a preterm baby because of the systemic absorption.
Yes, also according for availability also.
And I think for a fresh baby who is not colonized, normal saline is enough. عشان not to damage the skin like this.
We try to do like this, doctor, but after we are reviewing study, it's not recommended.
Take it from me.
Well, I
It
want
will
to
come
say,
one time
I want
in
to
the
save the
guidelines.
baby from this burn, يعني.
Thank you, Prof. Abdurrahman. I think we have one more comment from Dr. Talal. Last question, Manal.
Thank you very much for the presentation. It's a topic that I really struggle with all the time. I just have a few questions. What do you think about, there is a new dressing that is now available in NEPCO, and we're getting it even without ordering it, صراحة, which is chlorhexidine impregnated dressing. So the actual adhesive dressing has chlorhexidine in it as a gel, and it stays there for 7 days, and it omits chlorhexidine. It should be reducing the infection and colonization at that site. Now, is this applicable in neonates or not? That's my first question. My second comment, actually, I would say it's a yellow flag. I just want to put it out there that we're getting now new types of needleless connectors, the heparin lock, the closed system, whatever you want to call it. We're getting a new one, and this is the only one available right now. We are actually having some problems in the unit. It is blocked. It is causing accumulation of lipids, and I am not sure if I am the only person having this, because we had to remove a line twice for babies. So this is a yellow flag for everyone. Please, if you have something similar, please share it. Please, let's try to raise it if it's happening with other hospitals.
Sir, just I want to clarify with you. You just have 2 cases block?
So this is the cases that we have discovered, but we have multiple cases where the lines has been inserted less than 24 hours, and then the line was blocked, but we were never able to find out that the needleless connector is the cause. And I am thinking now, maybe how many cases we have missed before?
Doctor, it is, I think, maybe practice.
Could be.
I think it's practice, because it is rubber and valve, so maybe because of practice. Again, what? As what we call يعني anaphylactic?
Yeah.
It's not recommended, and we not use if there are no risk or something to start antibiotic. If this is your questions.
لا هو is an antibiotic impregnated lines زي الكلورهكسيدين impregnated lines that prevent the central line infection. At one time they get concerned that you may develop a lot of multi-resistance organism because of that antibiotics, but I think it was very useful. We don't see that much of eclampsia like now.
Maybe.
Dr. Talal, any other comments? Okay, any other comments from the audience? So thank you very much. Thank you, Ms. Manal.
Thank you.
Thank you very much.
Thank you.
Our next speaker for today is Ms. Al-Harbi. She is an advanced neonatal nurse practitioner. She is a senior specialist nurse. She has a master's degree in advanced neonatal nursing from the University of Nottingham, UK. And she is both Saudi and HA NRB instructor. And she is the head nurse of NICU level 3 in one of the tertiary hospital in Riyadh. So please just join me to welcome Ms. May. She is going to talk about a very important and debatable hot topics in the NICU, which is the feeding practices, but this time from the nursing perspective. So please.
Assalamu alaikum jami'an. I hope you're gonna have a very great day. So, as the doctor mentioned, he gave me like a brief introduction. Thank you, doctor. So today I'm gonna discuss with you one of the latest evidence-based practice feeding strategy, or we can call it approach, strategy, model of feeding. And also we're gonna go through the traditional feeding strategy. We go next. Okay. Okay. So this is our today's aims or objective. So we're gonna go through one of the NIDCAB theory, the active theory of development. Then we're gonna go through a quick anatomy and a neurologic review. After that, we're gonna highlight some of the traditional feeding approach, which is a volume-driven model. Then we're gonna go through the cue-based feeding approach, which is the latest and the most recommended one nowadays. Then we're gonna have a quick look at the latest evidence-based practice. So active theory of development, it's one of the NIDCAB theory, which is a subsystem integrated together. So the preterm, active theory of development provide a pace of the cue-based feeding model for the preterm infant. So the integration of these four subsystems gonna help us or give us a quick look for how the baby or how the preterm attempt the oral feeding. So as we know, the autonomic, the organization of heart and respiratory system, the infant must gain control of the autonomic function first, because of the ability, of the ability to achieve and maintain control of other subsystems. It depends on the function of the autonomic mechanism. Then the motor. As we know, the motor is gonna develop through the stages: antenatal, postnatal, and depends if the baby term and preterm, extreme preterm, how long it's gonna take. So the infant ability to achieve and maintain the tone, posture, and the smooth body movement. After that, the attentional, it's the sit within the state continuum, from the deep sleep to cry, and represented by the infant ability to adjust to response and the increase of refinement to alert, achieve attractive state. After that, the behavioral. So it's these four subsystems, it's gonna connect it to each other. So the behavioral, the infant's ability to transition from a sleep state to the full arousal, the pattern of the behavior state transition. After that, we will go with the a quick anatomy and neurologic review. So we will go with very quick through it. As we know, the oral cavity, pharynx, larynx, esophageal begin to develop at 4 to 8 weeks of the gestation and keep continue after birth. After that, at 9 weeks, the oral cavity, pharynx, esophageal are the three distinct anatomic regions that can function separately but are not yet function for swallowing. That's why this study, it's gonna give us a hint why we need to focus on the cue-based feeding. Then other reflexes, swallowing and sucking have been observed in uterus life as early 13 to 18 weeks gestation. However, the coordination of the two doesn't occur until 32 to 34 of gestation, for corrected age. Hence, the root response begin to develop at 28 weeks. Thought it's immature at that time. Coordination of the suck, swallow, and breathing does not occur until 37-week gestation, and it's often immature until closer to 40 weeks. Here, a traditional feeding. It's really common in NICU to hear some of these sentences. I don't know to how far you will agree with me. The baby reached full feed 30 cc, right? We got him to take 30 cc this session. He has able to take a full feed or a full bottle before discharge or before going home. Do we hear these sentences always, especially consultants? The main concern, how much the baby he can take or he can get, right? So this is called volume-driven rather than infant-driven approach. So as I mentioned, it's volume-driven rather than infant-driven. So driving oral feeding for a year, and I think it's still, until now, it exists. We are focusing on how much the baby is consuming rather than how much the baby, or how the baby he take it, right? One study said that, or stated that, volume-driven strategy include removing the blanket. This is especially nurses, they the one who really understand this sentence. He highlighted that volume-driven strategy include removing the blanket and feeding the infant unswaddled, which doesn't support the flexion. The preterm infants are often unable to maintain on their own. So this is one of his study he highlight. Always, especially this is nurses, they the one who gonna understand the point. A preterm baby, when we swaddle the baby, put the baby in a blanket and give him the feed, sometimes he will not take it. Unless she will remove the swaddle, she will give. You got it? I think you will not get it. So, like we are not swaddling the baby, one of the hints, if the baby, he is really a cue-based feeding, we can swaddle the baby and give feed. So the baby really attempt to take the feed, not the professional, they the one attempt to give the feed. The second things he highlighted, nurses would commonly select a nipple with an increased flow rate that is often too fast for the preterm infant to coordinate the three things: suck, swallow, and breathing. So he gonna take very high rate and always with the support of the chain. So we are kind of enforcing the baby to take the whole amount. So what is the consequences of the traditional or volume-driven feeding? One, or the first thing, the negative oral experience. So the infant or the preterm baby, he has experienced negative oral feeding and can cause the infant to develop compensatory strategy that can adversely affect the success at oral feeding. So the baby gonna stay with us a little bit longer. Okay? Second thing, or provide chain to the check to help or to prevent the escaping of the oral feeding from the oral cavity. So the research has shown that within the first 2 weeks, post-discharge from the NICU, 15% of the preterm infant are re-hospitalized again with feeding difficulties. Hence, success at oral feeding is typically judged by an infant oral consumption amount rather than the full assessment of the suck, swallow, breathe coordination. Preterm infants are often discharged home period to 30 PM age with the oral feeding skill still developed. I will give a question, just keep the answer between you and yourself. How many discharged baby you assess the 3 reflexes or the coordination between sucking, swallowing, and breathing? Keep the answer. Any discharged baby, do we assess the 3 things? And how the quality of that, if we assess it, okay? Then how can we attempt the cue-based feeding? By its kind of steps or kind of the elements, we can go through it, okay? These kind of elements, I put it into a slide. I will go through of these elements on evidence-based. So this element, it's gonna really highlight it or give us a hint how the quality of feeding that baby is having. So, first of all, research suggests an infant state of health and oral feeding experience are the 2 main factors that affect an infant progression of oral feeding. So, the garbage to oral feeding prior to the transition from garbage to oral feeding and before every oral feeding session, the infant should demonstrate signs of oral feeding, how he is ready, the readiness of oral feeding. We will not enforce this baby reach 32 weeks and he can suck. The attending physician or the assigned nurse, he check there is very good sucking reflexes. So we will start oral feeding. No, we also need to check how the baby ready. Is the baby ready? The readiness of the oral feeding as well. Also the showing of the hunger. This is the second hint to transfer from the garbage to the oral feeding. Second things, feeding scheduling. Okay, so feeding scheduling, oral feeding should be limited to 20 to 30 minutes per session. We will not give over 5 minutes or 20 minutes. We know we are facing shortage. We know sometimes we having the admission rate is very high. We are pushing the baby to be discharged. But really this is not getting the benefits for that baby. And we will be really at the high risk of readmission. So after 2 days, we will have the baby from ER. We readmit the baby again to level 2 or nursery for the poor feeding or poor oral feeding, or sometimes it's hypoglycemic. So we need to see how the baby is willing, the quality of that. So the scheduling, it should be take minimum 20 to 30 minutes per session. This includes time spent re-engaging, burping, or resting the infant. After 30 minutes, the infant is, it's like really showing he's full. Even we can check the burping equality. Sometimes he will not especially this one for the nurses. Baby will not burp with her. Baby always there is a leaking. He's not really taking the amount. All it's leaking. The baby doesn't take the 30 cc or the 25 cc or the 28 cc. Majority of the amount it's been leaked already. So there is no burping. Baby is still, it's like hypoactive, baby is still sleeping. He is still not ready to take that amount. Just give the baby rest, give the remaining of that amount as NGT. And you can combine between two of them. Do not be in a hurry to give the whole amount. As I mentioned here, the time interval is important to maintain that, to facilitate the sensation of hunger, sensation of full stomach at the end of the feeding, digestions, and the promotion the next feed cycle. What else? The bottle nipple. Especially this one nowadays, it's like a big struggle with NIPCO. The bottle quality, it's really, really important. We need to select the, we will not say the premium, but the good quality one. If you don't like that kind of nipple, if you don't like that kind of bottle, you can reject it, you can request another one. And also you can already complain against that bottle. So once the infant has demonstrated all signs of oral feeding, readiness, a bottle nipple must be selected to begin oral feeding. Selected an appropriate bottle nipple for the infant is very important because the flow rate can affect the respiration, feeding ability, and the swallowing safety. Second thing, we will go through it. The oral feeding readiness. Prior to each oral feeding session, the infant should demonstrate a flexed body position, as we mentioned earlier with the traditional one. The study highlighted and swaddled baby. For oral feeding, think about the way of the adult eat. They sit up straight with their head, neck, and trunk aligned, and with their hands at the midline, bringing the food to their mouth. The same concept holds true for infants. However, premature infants are often not able to support the flexed body position on their own. Therefore, to support the flexion, the feeder should swaddle the infant with infant's hand up toward their face midline. Pacing, external pacing provide the infant with a smaller bolus size and decrease the flow rate to allow the infant to the bottle manager the flow rate and coordinate the suck-swallow breathing. Engagement in the feeding, the ability to remain engaged in the feeding implies the infant is able to demonstrate sufficient energy for the feeding, maintain an awake and focused state throughout their entire feeding. A premature infants often have difficulty remaining engaged. Therefore, improvement in this skill is the one of the first step to success oral feeding. Oral motor function. So, according to the baby gestational age, you can really say that out loud. But sometimes the baby develop their reflexes and their motor function earlier. So the infant's oral motor organization should be assessed at the onset of the feeding and the onset of the feeding underway. At onset, a skilled feeder would open his mouth and descend his tongue promptly when his lips are struck with the bottle nipple. So this is, you can do it with the early morning assessment. You can't really say that. Yani, check that. When you're gonna check the infant like sucking reflexes and the other reflexes. You can do it with the nipples. And psychological stability. Here. Psychological stability, the next area to assist and respond to giving cues is the infant's ability to maintain psychological stability without excessive work of breathing. This area of assessment is very important, especially at the beginning of the feeding as the infant becomes fatigued. So that's it. To be considered, research suggests that an infant state of health and oral feeding experience, as we mentioned earlier, are the two main factors that affect infant progression of oral feeding. Here's the latest evidence-based practice. All of them are supporting really the cue-based feeding. So in 2025, so it's recently published, systematic review and meta-analysis, cue-based feeding has the potential, the time to achieve full oral feeding, reduce the incidence of feeding intolerance, and to promote the parent's involvement in the feeding behavior for the preterm infant. Another study stated that a cue-based feeding decreases time to achieve full oral feeding, decrease length of stay, increase the parents' involvement in the feeding process, and resulted in the cost saving for the institution. This is gonna really go with this new holding company. So we will support this new based evidence of a cue-based feeding. Another systematic review, this was conducted in 2021, found that many neonatal units are considering implementing a cue-based feeding. But until now, all the study really highly recommended the cue-based feeding. But in the reality, we are still going with the volume-driven feeding. So still, it's debatable. This is my references. At the end, always we're gonna, and we need, and we're gonna really highlight the equality of feeding, not the quantity of feeding. So the baby at the end gonna achieve the amount of feeding. A baby at the end gonna gain the targeted calorie and the weight, but also we need to help the family at the end with the equality of oral feeding, and we're gonna help the baby itself by himself or herself by the quality of feeding itself. So always focus on the quantity and the quality, not the quantity. So thanks for being a part of this feeding journey.
Thank you very much. Thank you, Mai. Thank you. A very meaningful presentation, updated information, so thank you very much. We will just allow the questions and open the floor for the comments. And we can start from which may ended by, is it still debatable or no? Abu Bandar, yes?
Even the consultant, they the one who said 30 cc. So, yes, yes.
Regarding the feeding, thank you for the presentation. Regarding the feeding, usual problem we face for those babies during feeding, the desats. That, you know, all the time the nurses, they said the baby desatting, baby desatting. And many times we delay the discharge, waiting for the babies to stop desatting during feeding. What is your opinion about that? Is it part of your preparation of the baby to stop desatting, or stop the monitor?
No,
stop
actually,
I asked them, stop the monitor and feed the baby.
This is going to highlight one of the principles of the EQ-based feeding. How the baby ready, is the baby ready? The readiness of oral feeding. So it's like, it's going to highlight even, we're going to go back to the autonomic or the reflexive. There is no coordination between swallowing and, between sucking and the swallow. That's why the baby is desatting.
Because I think even normal babies, term babies, normal, they may desat. You found them a little bit bluish, you know, when they feed. It's a matter of like, you know, technique of feeding rather than the baby is sick. But we get so worried for those tiny babies that they are ready to go home. Many times we delay them because of this issue, waiting for them to stop desatting during, like, you know, feeding.
He's not ready to be discharged. He wants to stay with you, doctor, really. He wants a little bit of time.
Though he's ready otherwise. We mean, like, you know, temperature control, weight-wise, family readiness, everybody is ready. But the mother come and sit and feed the baby desat a little bit down to mid-80s, and the nurse will say, okay, the baby desatting.
He's not
We need to delay him.
Still, he's not willing.
I can comment on this. When we face it, we call the mother to come and feed the baby. This is the time the mother, she will come to do attached to her baby, share with the feeding. Most of this baby, they improve their DSAT. Let the mother get room in before they go home. This is maybe one of the solutions. My question to you is the cup feeding. Many of neonatologists here, they believe on cup feeding not to cause confusion. Do we have this practice here? When we start oral feeding, we start them with the cup feeding?
Actually,
And what-
before we need to start cup feeding, we need to start the CQ based feeding. Is the baby willing? Is the baby, it's like in a hunger? Is he ready to be
Wallahi-
oral feeding? Then we can start cupping, we start cupping feeding, we can start other technique or feeding approach. But this Q-based feeding, it's gonna really give us a hint to be transferred from cavity or pumping feeding or whatever to the oral feeding. So if the baby readiness skill is available, we can go with so many like oral feeding approach.
Well, cup feeding mainly not to cause nipple confusion, and let the baby start from the beginning. Just drink, and the time you discharge him, he will be in the breast.
But still the baby gonna use the three skill,
Right.
sucking, swallowing and the breathing. So
We need to
still
hear from
we
the
need-
nursing also.
Yes, can you hear from the other perspectives? Okay. Any other comments? Because I think we have another 2 minutes if anyone would like to comment. Dr. Abdul Hakim, does that, when we hear about cyanosis during feed, does that need further investigation? Sometimes we'll be rushed to do another investigations. We'll ask to do refluxing things, echo sometimes, just to rule out organic causes.
Don't involve the speech therapist, because they will ask you to stop feeding him and put the tube and avoid and go for swallowing studies. I think it's maturation issue, plus overwork him for not in the proper place. That most of those babies, if we wait for them 4 or 5 days, they improve and they will go home. And when the mother is really insisting and she is involved, I tell her, don't look at the monitor, just look at your baby. If the baby is feeding and happy, and if you found him, he has difficulty, stop him, burp him, wait for him for a few seconds, and then restart again. And that solves most of the problem. But really, to go for more investigation, I think you will not find anything most of the time.
So
It's a maturation issue.
your words, doctor, now it's really supporting Q-based feeding.
Of course,
Yes.
you should, of course.
Yeah.
Of course, we should. We have no other choice.
Thank you, May. Thank you very much.
All right. Thank you, everyone.
Any further comments from your side?
Just always focus on this is a takeaway message. Focus on the quality, not the quantity, please, especially for consultant. The baby gonna be discharged, really, don't worry. Baby gonna discharge, but we need to discharge him with really good quality of oral feeding. So always, this is the takeaway message. Focus on the quality, not the quantity. Thank you, everyone. Thank you.
Thank you very much. Now we are moving to our third speaker of this sessions. Please allow me to welcome Ms. Hana Al-Ghamdi, who is a senior neonatal critical care nursing specialist with more than 15 years expertise in the NICU, and she is an OSCE examiner in the Saudi Commission, and she is certified in neonatal resuscitation and developmental care. Hana will talk about the nursing leadership in neonatal ventilator management. So please, Hana, floor for you.
Thank you, Doctor. First of all, I would like to thank that Saudi Neonatology Society for that giving me the opportunity to give you these lectures. And first of all, we will talk my lectures. It is very important lectures, which is that nursing leadership in the neonatal ventilator management. So what is the evidence-based according to in the leadership? We will see the evidence-based practice, the last ones, okay, which is helping us in the neonatal ventilator management. Okay, we will talk about that, recognize the role of the nursing leadership, okay? What is the, we will talk about recognize the role of the nursing leadership in the preventing the ventilator-induced lung injury among the preterm infants. And also we'll identify the evidence-based ventilations and the airway management practice that support the lung protection in ICU. And also we'll analyze the local data trends that related to the pulmonary hemorrhage and also the link to the ventilator care, especially to the nursing. And then after that, we'll explore the impact of the standardized nursing lead intervention on the neonatal outcomes. Okay. As we can see here, okay. Now, protecting the tiny lungs from the big machines. Every breath, it matters, actually, in the ICU. And also, we are discovered that even the few centimeters, okay, could decide you can save the lives of the baby or can be harming the lives of the baby. And also, we have to think about the big ventilators. How can we save the baby, the tiny lungs from the big ventilators? So this is our role, especially I'm talking to the nurses. This is our role because you are always the bedside of the patients for 24 hours, okay? I cannot say it is the RT or the doctor. It is our job as a nurses because we are the one who is staying with the baby for 24 hours and we can save their lives and we can harm their lives. It is in our hands, okay? Then, what is some practice that we can be managed or it can be in our hands as a nurses? We can save the lives through that's what? High the pressure it can be, yes, if we are not focusing, and also the large volumes that is coming from the ventilators, and also unsafe suctioning, okay? And the nursing, always the nursing leadership, what I'm focusing about the leadership because they are standing as the front lines of the protection. They will be ensured for all the nurses they are giving that gentle ventilation and safe suctions and also continues the waveform monitorings. So through what? They will through the educations and also through that to be sure that every nurse, she is competent to give a care for these fragile neonates. Okay. If we will go and to the next slide, can nursing leadership truly make the difference in the preventing ventilator-induced lung injury? Okay, so this is very important questions. Is the nursing leadership can help or not? Okay, if we'll go to the next, okay, if we will see here, globally, we are having that 40 to 60%, okay, of the ventilated preterm infants worldwide develop the ventilator-induced lung injury, and about 25 to 30 of the chronic lung disease cases in ICU. If we will see locally, actually, we don't have that specific data because insufficient. I was searching in the Saudi Arabia. But however, what I found that Saudi in ICU data, it show high chronic lung morbidity. It is about 30 to 49. It is depending on the gestational age. Okay, let's now in covering the gap. What is the nursing leadership can make the difference? Now, let's look what is the evidence say about the nursing lead ventilator management. Okay, so this studies, it is show measurable clinical benefits when the nurses take the active leadership roles. When the nurses, they will lead the standardized weaning and ventilation protocols, the duration of the mechanical ventilation will be decreased. Okay, it is about the 12 to 20 hours, which means that is less exposure to the ventilator-induced lung injury, so we can prevent. If we will go to the next, okay, we will see that the ICU stay, it will be decreased, okay, it will be shorter, about 0.7 of the staying in ICU, which is very important, okay? Then if we will go to also the same study, it's showing us, that's proving us, the same search that's revealed there is a gap. Only 38 of the nurses, of the neonatal nurse, are having the lead or adjusting the ventilator parameters. So that 76 of the person, they said they want to lead the quality management, but they don't having the authority to do it. So if we are comparing with the other studies, okay, or other units who are having the structural nurse leadership, okay, what they are showing, let's do it this one, okay? They are showing that already they are having the structured nurse leadership. They will show that 15 to 20%, they are lower who is having the standardized leadership programs. They are finding that it is decreased about 15 to 20% if they are giving the authority to the nurses to lead and to good leadership in these units. So the same data, so at the end, it is very important. If you want something, it is very simple. If that data is showing us something, it's very important. If the nurses, they are empowered, the outcomes will be improved. If the nurse, the collaboration, it is limited, the complication will be increased. This is the very important things about the nursing leadership in ICU. Okay, let's go to the next. Okay, if we are seeing here that mechanical ventilation always in the extreme terms, okay, infants from 22 to 28 weeks, okay, it's showing that multi-center studies that confirm that is the neonates who's between these weeks, okay, they will require that mechanical ventilations and during their stay in the NICU, while that nearly that 50% of that babies are remain, still they will need for the mechanical ventilation for at least 3 weeks or more. The research also indicates that very preterm babies require that prolonged that mechanical ventilation. If they are exposing to the mechanical ventilation, so the complication will be increased. So it is very important to allow the nurses to lead, to protect and the ventilator care, especially the senior staff. Give them the chance to educate and to lead the good teaching, good education in the units. Because prolonged ventilation, it is not only a technological challenge. Actually, it is a leadership opportunity to prevent this injury. Okay, if we will go and see this one, the X-ray, this is what is that showing us if we are having the pattern of the ventilator-induced lung injury. But if you will see the pictures on the left and the right side of that slides, we are seeing the normal lungs, which is the normal lungs. That's what's showing in the X-ray, the inflated, clear, and symmetricals, and this is our aims. So if we will see the if we will see the one in the middle, okay, we will see a large pneumothorax. This is one of that. It can be the complication of the ventilations. And if we will see the last pictures, which is in the left of the slides, okay, we'll see the lung collapse. So all of this injury, it can be prevented, okay? It is in our hands, what I'm talking to the nurses, okay? Do not allow the baby to reach to this point. We can prevent it, okay? So it will be showing how can we protect or we can injure the neonatal lungs. So that means every breath, it is matters. So if we'll go to the next, we will see the evidence and support of the best practice standard to support the safe airway and the ventilation management in ICU. Okay, as we can see here, the clinical practice, okay, this is the slide. It will represent the evidence-based practice, okay, which is helping us to protect the lung. One of it is the early non-invasive ventilations, okay? We are always recommending the non-invasive ventilations, okay, like that nasal CPAP. It is the first line management of the respiratory distress. It will helping us to reduce the mortality and also bronchopulmonary disease compared with the early intubations. If we'll go on to the next, which is LISA and SALSA techniques, okay, this is for the surfactant deliveries, okay. It is less invasive surfactant, and also I will not intubate the baby to give the surfactant, so this one, it will give me the chance, okay, to give the baby the surfactant, which is already talked about it, Dr. Saad, about the SALSA and LISA, which was amazing lecture yesterday. So if we'll go to the next, we are talking about the lung protective mechanical ventilation, okay? So what that means, it is when the intubation it is necessary is the volume target modes, it will helping us to minimize the volume trauma. So it is very important to think about it to improve the outcomes of the neonates. If we'll go to the pre-oxygenation before airway manipulation, this is very important, especially for the nurses, before you are doing suction, before you are doing any procedure related to the airway, you have to pre-oxygenate. Okay, so if we'll go on to the next, maintain the ventilator humidity and the temperatures. Okay, this is maybe some of the hospital, what I have seen, they are not thinking about the humidity. They are thinking like this, the humidity is accessory in the ventilator, so some nurses, they will think, okay, I will check, and some hospital, they don't have the RT, or they are having the shortage of the RT, so we are demanding with the nurses. If you are seeing that there is no humidity, you have to inform the RT, you have to follow them, or otherwise you can do it by yourself, because some of the MOH hospital, really we don't have that enough the RT to see their, to see and to be helping us to maintain the airway. Because really it is a big challenge, especially for the Ministry of the Health hospitals. Okay, if we will go to the next, clinical practice, okay, we'll continue. We'll use the accurate suction depth. This is very important. We don't want to use the aggressive suction, because why the aggressive suction? It is one of the risk for the pulmonary hemorrhage. Okay, we have seen a lot, okay, in that hospitals, some RT, some nurses, even some doctors, they are doing the aggressive suctioning. So they are doing the aggressive suction. Okay, what can happen? Many complications. One of that one, it will be the pulmonary hemorrhage. We have to use the accurate suction depth, okay, to prevent the mucosal trauma, and also this is one of the factors, or that we can see the modifiable factors that can be targeted by the nursing leadership. And we should be gentle and clinically indicated suction only. We should not do suction. Some of the hospital, they are doing a suction as a routine every 2 hours, every 3 hours. It is as indicated, okay? If the baby is needed, we have to do it. It is not a routine. And we have to limited use of the salines. This is very important, okay? Because this will be risk of the inflammation. And also, we developed the universal use of the closed suction. It should be used for the closed suction system. It is helping us to prevent the infection. It will helping us to maintain the ventilation during doing the suction. And compared to the open suction, it will be used as needed and should be with the assist of the RT. It is not as a routine as we can mention. Okay, let's go to the next. We will talk about the safety and leadership practice. Okay. The safety and leadership practice, it is the strategic, it is nursing lead system. We have to be ensured that care and the quality, it is continue to monitor and prevention of the complications. Regular audit of the humidity and the suction depth and the airway pressure, it is very important. And also the staff competency and interdisciplinary collaborations. We have to work with the RT, with the doctors about everything, especially during the rounds. The nurse should be there and she have to give her opinion about the baby when they will be asking about her. The leadership, it will be driven that educations, okay, and monitorings. About what? Continues the feedback, data tracking and monitoring and continue educations. And also the evidence-based standardizations, it is that the nursing leadership team at Al Yamama Hospital in the collaboration with the nursing education departments and respiratory therapist teams, we have focused, we did a project and we focused on that suction and the airway managements to decrease that pulmonary hemorrhage, because it was one of the, what we have seen, it is one of the mortality in ICU. And that we focus in the suction and airway care because this can be handled by the nurses, and it can be, this is one of the risk of the pulmonary hemorrhage. Okay, now the same questions. So let's go to that, the project. We did the project. It's about the standardized airway and the suction practice for enhanced that neonatal outcomes in Al Yamama Hospital. Sometimes we are seeing that the routines, our routine works. Small habits, it can cause that major impacts on the outcomes. Okay, we have to think. This is that questions, it was inspiring us in the journey to review how the nursing practice can directly improve the neonatal respiratory outcomes. It was our goal, okay, to create the one standard, one voice, and every nurse speak one language, one clinical language, so when we are providing the airway care. Okay, before we have a problem. What is the problem? It was the variability in the suction depth and the pre-oxygenation across all of the team. When I will go to the one nurse, she will tell me I have to stop here. When I will go to the RT, I have to stop here. Everyone have their practice. So if I will ask one of the senior staff and I will tell her, please, can you teach the new staff? And she will teach her in her style. And about the depth, it is according to her. Actually, there is no standardized when I have to stop. Even when they are telling me, okay, I have to stop in this number. Which number? Depend on what? This number, it is different from the other nurses. So we are trying to speak one language and we are trying to make it our clinical language one. So this is one because we are having the variability and also the limited availability of the closed suction catheters, okay, and the humidification use. The closed suction, it was available but limited. Why? Because some of the nurses, yes, also some of the doctors, some of the RTs, okay, I can say 70% of all of them, or 80%, they was not believing of the closed suction, and once we are connecting the closed suction, they like to do the open suction, and some of them, they are doing every 3 hours, every 2 hours as a routine. This is ventilated baby, so I need to do a suction. They are not thinking about all the factors that is affecting why this secretion still it is coming out. They have to think about it. But they are focusing, no, I have to clear whatever. Every hour, every 2 hours, doesn't matter. Open, close, it doesn't matter. So what we found that when we are doing that is that our database from Al Yamama, we have found in 2023 that pulmonary hemorrhage cases, it is 23. It is too much, okay? If we are seeing that death related to these cases, it was 18. So what is about the mortality rate? It is 78. If we will see in 2024, we was having 20 cases, okay? And that pH related the deaths, it was 14. So the mortality is still high, it is 70. After we are applying, okay, that case, it was 8, okay? But this 8, some of the cases still, I have found some of the nurses from this of the 8, some of the nurses still, it was the reason they are aggressive. And some of that, I know the pulmonary hemorrhage, it is having many reasons. It can be because of the prematurity, it can be because of the coagulopathy, because maybe if you are giving the surfactant effect. But this is all reasons. But the reason that I can be handled by the nurses, it is that the aggressive suctioning and the open, and also that airway care, the humidity, pre-oxygenate, I'm using normal saline, all of these things, it can be risk for the pulmonary hemorrhage. Okay. I will do the comparison, okay, of the local and the global pulmonary hemorrhage, what we have seen, in the global, it is from 1 to 12. What about that in the Al Yamama? Still 5.1, so it is in between. If we will see the mortality according to the global, it is from 30 to 60, but for us, it was 78, which is very high. What about that now, 2025? Still we are following, still not finished the years, but we hope, inshallah, we will be less. And the next year will be more less. So if we will go to the next, we are saying that what is that? At the beginning, okay, what we did, we decided to focus in the training of the nurse. Our first goal, okay? It was to maintain the safe airway practice in the NICU. It was our objective to standardize the airway care practice across all the shifts, EM, BM, night, EM or nights or whatever. Okay, we have trained them one by one, so I will be clearly to my message, it will be reached to everyone. So I am taking one by one. There was around 83 staff, so it was taking time, yes, but the outcomes, what we want to reach, it is worth. So we was focusing about the airway safety, we are focusing about the safe suction depth, we are focusing about the pre-oxygenate, about the fixation of the ATT, about the assisting of that, how you are helping the doctor, about the aseptic suctioning technique, if the baby need for the open suction, what you have to do. All of these things, we are focusing about it. So it was from 20 to 23, there was 0. From 24, it was only 12. So we reached in 25 to the 18. If we will see here, okay, it was some of that training of the staff. We are training for that competency, and we are focusing about all of that needed for the airway care. We make that closed suction available in every shift, and we train even the RT to helping us for the fixation of the closed suctions, and also helping us for the humidification, helping the nurses for the airway care, because also this is main role of the RT. Okay, not only the nurses. Okay, what we did, we locally developed a suction depth, okay, for the according to the ATT size, okay. So I'm just doing this study and just need to be under published, but still we are waiting. So what is that? Is the when I'm telling for the staff, we have to speak one language. I'm giving them that recommended the suction catheter depth according to the ATT size. According to the ATT size, if I will tell them that 2.5, if what is the depth, it will be 16, and 3.18, 3.5, 20. It was our aim to prevent not to pass the end of the ATT. So all of the staff, they are having a one language. So when I will tell the nurse, what is that, if you are having 2.5, what is your depth? 2.5. I will go to the senior, junior, RT, doctor, all they will tell me is 16, where I have to stop. Because my point, I don't want the tip of the catheter to pass the end of the ATT, because once I am doing like this, what is happening? I am causing the injury to the mucosal, okay? Once every day, every time I am causing the injury, 100% the injury will happen. Pulmonary hemorrhage will be the one of the factors. So this is very important. Really, this one, it was helping us, for us as a nurses, okay? Now, if you will go to Al Yamama hospital and ask the junior, I'm not asking the senior, ask the junior, where you will stop about, if you are having the baby with the 3.5, she will tell you 20. Unless if we are cutting the ATT tube, okay, that time we will make the new measurements for only this baby. But usually all we are following this chart. Now, when we are saying, when we are training the staff, we are saying we are reaching to the 20, and the cases, it is decreased to the 8. And I hope, inshallah, at the end of that years, we are having, it will not be increased, I hopefully. If it is increased, so next year we will try to make it half until we have 0, because this is our goal, but at least there is some improvements. I will tell you something, that nurses, they are the front line of that baby care, because they are the one who is beside of the baby. They are the one who can give a good care or can harm the baby. So it is very important to train the nurses very well and give them a clear instructions. Do not give them many things and let them confused. 1 and 2 and 3, just follow it. Because as we can know that the nurses also, they are suffering from the shortage of the staff, from the high ratio, so we have to keeping this one also in our minds. Okay, this is the pictures for my leaders, okay. At the start of the 2025, I was personally trained every nurse to ensure that I'm having the unified and the safe airway practice. But to keep this effort live, okay, and with the 83, I'm only one, so I was needed for the 12 leaders, okay? So these 12 leaders, they are really helping, and I'm really appreciating. So if each leader, I'm giving them that name of the flowers, so they will be happy with that. As you can see, that's sunflowers, tulip, orchid, and lotus, and all. So every team leader, okay, she will have 2 sub-leaders. She is responsible about 2 sub-leaders. She will be following with them everything. What is the message? It is coming from me, if it is coming from the head nurse, or any new practice, any new machines, okay, I will be the one responsible to teach the 12. So the 12, what they are doing, each team leader, she is responsible about only 2. Because I'm thinking also about the staff. They are also bedside, so they are having the patients. So we are trying to delegate the works. I don't want one nurse or one leader, she will be responsible about the 7 or 8. So I'm asking her to be responsible about only 2, with the R sub-leader. The 2 sub-leader, each sub-leader, she is having also 2. So like this, we are delegating. So every nurse, she is responsible. The senior, she will be responsible about 2 of the staff, and 2 of the staff sub-leader, one of each of these 2, she will be responsible about the 2. So now we are delegating the works. Now we are having that really amazing team, and they are really helping me to keep this practice really alive and to be continuous. And if there is something, I am just following with the leaders, with some of the staff. She will helping me to teach the staff, and that's it. As I am, she will be educator, she will be clinical instructor, she will be like a mini head nurse responsible about her staff. And one thing, through that strong nursing leadership and the evidence-based practice implementation, I'm sure 100% the outcomes for that neonates, it will be improved. So at the end, the nursing leadership, it is the key to protecting that tiny lungs, okay? It will be the most preventable persistence causes of this morbidity in the preterm infants. And also it can be the leadership and the education transform that practice when the nurses are empowered, lead and audit. And the outcomes 100%, as I mentioned, it will be improved. And thank you for your attendance. If you are...
Thank you. Thank you very much. Thank you, Ms. Hannah, for this great work and dedication. And actually, work with the quality, it should be a standard of care. On daily basis, not a mere request. Again, I do believe neonatal nurses are not only the front line in the neonatal care, actually they are a cornerstone in the neonatal care. The high qualified in ICU cannot functioning very well without a competent and qualified neonatal nurse. If you have any questions or comment for Ms. Hannah, the floor is for you.
From the nurses, where is the nurses? They are shy.
First of all, thank you so much, Hannah. ما شاء الله أنت بالكويت وايد فتينا، أهم من هنا فإحنا جايين لك عشان نستفيد منك أكثر وأكثر.
Thank you.
الله يعطيك العافية. أنا بس عندي سؤال، شنو الفسيولوجيكال إمباكت على النيجاتيف اللي هي النيجاتيف تاتش تبع الأجريسيف سكشن؟ شنو ممكن يأثر على اللونج تيرم مثلا في
Actually, that when we are doing always aggressive suctioning, okay, it can be one of the risk for the pulmonary hemorrhage. So that the mortality actually it is very high with the pulmonary. Once the baby they will have the pulmonary hemorrhage, really the mortality it is very high. So even if the baby will be safe, they will be risk for that bronchopulmonary dysplasia. This is one of the risks. So we are trying to prevent it from the beginning, okay, any injury to the lungs, okay? Thank you, Khalid.
You didn't introduce yourself. I'm a nurse now. If you remember my first question and the first session with Joseph New, when I told him the BBD start from the resistance of the nurse to extubate the baby early if he's ready for extubation.
Yes.
And now we are supporting this, huh?
Yes.
So nurses are the cause of the BBD.
Yeah, always listen to the nurse. Because when she is saying no, really it is no, especially if it is coming from the experience or senior staff. Because she is always the one who is beside of the baby for 24 hours and she knows. And if really this baby, and at the end, I have seen many cases, at the end really this baby, he will need to re-intubate. This is what is happening.
Pulmonary hemorrhage, I thought it is not from the airway hemorrhage.
Yes.
What the one causing significant mortality is the BDA, hemorrhagic pulmonary edema, صح؟ ما أعتقد النيرسز لها يعني دور في السكشن والحاجات هذه.
Actually, if we are seeing some of the MOH hospitals and some of that practice, really this is coming from my observation, the aggressive suctions, it is happening. And they are doing every time, because sometimes when they are using unmeasurable catheters, open, unmeasurable, they don't know when they will stop. They will just stop when they will feel there is a click. Every time, tack, tack, tack. So what will happen?
And does the one lead to pulmonary hemorrhage to death?
Yeah, it is really, wallahi, really. It is in Al Yamama, what I have seen, it is aggressive suction. If they are doing every 2 hours, especially for the extremely premature babies, they will not tolerate.
If you allow me, I just want to follow up what you said. I couldn't agree more with what you said about suctioning, especially open suctioning. We've seen this a lot, and I think, Prof. Abdulrahman, the reason behind it is probably the loss of FRC. When they disconnect, you get a deflation of the lung, you lose recruitment.
Yes, yes.
The pulmonary vascular resistance actually is the one that is driving the PDA to the other side and is kind of protecting the lungs from the negative effect of the PDA.
But,
by suctioning,
yes.
by negative pressure itself will make you lose recruitment, and on top of that, keeping it open is going to make it even worse.
Actually, doctor, yes, when you are doing open suction, okay, sometimes you are taking a time to do the suction, okay? Some, I cannot say the nurses or really, the doctor, nurses, the RT, some they are taking a time to do the suction, more than 10 seconds. Once you are disconnected the baby from the ventilator for more than 10 seconds, you are making that pressure which is in the alveoli to be less, which is you are allowing the lung to be collapsed. This is one. And the second one, I am not saying that the closed suction or open the suction, it is the main reason for the pulmonary hemorrhage. But one, it is the multi-factors that we can control. Because behind of this one, we are having that you are disconnecting the baby, and you are having the high pressure that is coming from the machine. Some, they are having more pressure when they are doing suction, they will exceed that 100, which should be used from the 60 to 80 for the premature baby and from 80 to 100 for the term baby. But if we are seeing these cases with that, even with the term baby, with that injury, sometimes the blood it is coming when they are doing that, and with the term baby, really it is making us questions why this one it is happening, okay? Because we are having that, we are not do pre-oxygenate, we are increasing the pressure during that, we are doing the suction, and we don't know every time, every like 2 or 3 hours we are doing. And I'm not saying this practice only in the Al Yamama hospital, really I have seen in many hospitals, especially the Ministry of the Health, MOH hospital, because as I mentioned, when I will ask the nurses, they don't have that. I will stop. Some they will stop, okay. It will be away from the end of the ATT because she is afraid that she will cause something. Then after that, what will happen for the ATT? It will be blocked with the secretion because she is not clearing the secretions. So I'm just trying to make all the nurses to speak one language. Just when you are doing this one, just do that. But actually, it was when I did the project, I was not focusing about pulmonary hemorrhage. I was focusing to make our language once, okay? But during that time, we have found that the units no more pulmonary hemorrhage because when we are coming to this one, why? This is our questions. But when we did the project and we are allowing the nurses to improve their outcomes, even the RT, we have found it is drop. And actually, it was. I can say it, really, it was not my, I cannot say it was my main goal, but it was my main goal. I don't want to see the aggressive suction. When we are prevented, really, we have seen the effects. But I'm happy with the results. Still, I'm not happy because behind of this one, it is many reasons for the pulmonary hemorrhage. It is that as large PDA, we are having the coagulopathy causes and prematurities. All of these factors, it can be played in that causes of the pulmonary hemorrhage. This is the problem. Before there was resist to use the closed suction. They doesn't like, but now, alhamdulillah, they are asking for the closed suction, all of them. Yeah, now it is mandatory for all ventilated babies. But before, actually, unfortunately, it was not. And they was complaining about the company, but actually it was not. Only it was about the practice.
Perfect.
But, yeah.
Perfect, Ustana. Thank you very much.
So
it was more of observational study rather than your main goal.
Yes.
This is what you mean.
Yes.
So before we wrap up our the first session, yeah, of course, Dr. Jabara will have a comment.
Yeah, thank you very much, Hana, for this presentation. أنا شهادتي في Miss Hana مجروحة. I know Miss Hana very long time from Baljurashi. I saw her first time the NRP course. I was excited. She know how to intubate. So I asked her, and I was discovered she was intubating baby in the NICU, helping the doctors, inserting UVC. She was really young, energetic. nurse. I was really very happy for having her again and again.
Thank you, Doctor.
Yes, excellent, Hana. Thank you very much.
Thank you, Doctor.
And my question, thank you, yes. You deserve it. Again, please. Excellent. So my question, I'm really impressed about the significant reduction in pulmonary hemorrhage. Did you notice during that time any medical changes, like using higher PEEP, or there is BDA treatment, any other medical intervention rather than just a nursing issue?
Actually, when we are seeing that cases, some babies, they was having the large BDA, okay? It can be counted, that's one of the cause of the pulmonary hemorrhage. Some they was having that. The change, really it is not documented actually in the data. They are documenting only the numbers, okay? And only the diagnosis. But what is the behind of this story, it is not mentioned in the data. This is the issue. So it is not full of the data in our database. Yeah, my message really, when the nurses, when that they are giving them the empowerment, okay, that we are having them the empower to lead, to be a leadership, okay, to be a leaders, really they will show you the amazing works. Because the nurses here, the 12 leaders, I'm just selecting them based on their what is the backgrounds and also how she is leading with the new staffs. I'm selecting them, but what they did, it was amazing, okay? When I'm telling them that you will be responsible about your team, and really, when they are leading the staff, they are leading from A to Z. And really, when you are giving the nurses, give them the power to lead, give them the authority. Do not limit their work, especially in the units, because when you are giving them the power, amazing outcomes you will see. And also you have to think about the shortage. Do not give them the overload, okay? This is very important. Anything you will see in the ministry, we don't know where to put, okay, give to the nurses. This is overload, okay? 100% the outcomes will be decreased. So we are trying to balance between that, giving the power, okay, to lead, and try to delegate, to decrease, and not giving them that works. This is what we are. Yeah, we will give you.
Great, Hannah, thank you.
Thank you.
Your topic, I'm sorry, I don't want to rush you, but your topic seems to grab attention. So, Doctor, we allow us to have two more questions. First with Dr. Yahya.
Regarding the closed section, if really the nurses are competent, no need to do the open section.
Yes.
Yeah,
yes.
No need to do the open section because closed section is very good, and if you will adjust the pressure, there is no incident of pulmonary hemorrhage. Okay.
Yes, agree. Yes.
Because for us, it's very, very, very less. Maybe 1% only we have pulmonary hemorrhage. It's because of the baby's condition.
Yes, I agree with you.
It's not related to any mechanical issues.
Yes.
Okay.
Yes.
The other thing, the length of the suction, the catheter, you mentioned 16, but it varies according to the cutting of the ETT. Usually we are cutting the length of the ETT to reduce the dead space. So it will vary according to, it's not actually 16,
yes.
And there is measurements in the closed section. We can relay on that one.
Yes, okay. Finish?
Yeah, and for the nurses, actually for us, we are very competent. Before going to the patient side, we have competencies with our CRN and with our educators. So we are very competent, and for our practice, the CRN and educators, they are doing the rounds, and if we are doing some procedures, they are coming and they are checking the pressure of the suction machine and how they are doing.
Yeah.
And so it's easy if you have some like CRN or educators and they are doing the rounds, you can reduce the incident of the pulmonary hemorrhage also there.
Actually, as you are mentioning, about the last questions, okay, to make that CRN work, because you are having the huge number of the nurses, okay, and you need to be focused not only in the morning, I need to be focused in the morning and in the nights, okay, if we are having 12 hours. So I will not be presented, or my team will be presented every 24 hours. So that the leaders, okay, they are helping us really, and they are working as an educator for all the nurses, especially if they are beside with the junior staff. They will be sure all the steps are doing very well. And also we are having the audit tools to follow with them. This is one. What about that when we are cutting the suction? Yeah, I have mentioned when we are cutting the ATT, okay, the measurement it will be different. But when I was trying for that to measure that you are matching the number of the closed suction with that ATT. When I was trying, especially for the 2.5 and the 3 and 3.5, what I am seeing, the tip of the catheter, it is going out. Okay, it is past the end of the ATT. It was my point, it should not be past the hole, which is beside of the ATT. So with these measurements, okay, it is when I did the 16, and I'm telling the staff, okay, 2.5, it will be 16, plus 2, when you will have 3, 18, plus 2, it will be 20. So it will be easy for them to remember. So because this is one of the practice, it was done. We have to match the number. But when I did, really, it is pass. So for my point, it should not be pass. So with these measurements, really, it is helping us. Unless if you are cut, you have to measure only specific for these babies.
Yes.
So did I answer your question?
Thank you so much.
Thank you for you.
Thank you for your comment. Dr. Yahya, please.
Thank you, Ms. Hannah, again. I feel very happy, actually, to see every year a new leader of nursing in the field of neonatology.
Thank you.
And that's an amazing. I do strongly believe that an expert nurses in the field of neonatology, it is an important, like a presence of a consultant of neonatology. That's really reflecting the care of neonatal outcomes, and it make a difference, especially my own, and I'm sure my seniors, all they passed through this story and worked in hospitals that were with no expert nurses, and nowadays they have an expert, and they saw the difference before and after.
Yes.
My question to you, and the other point to the scientific committee. Actually, it's away from your nice presentation, but how can we build up, especially in the periphery, a new nurses with an experience of neonatology in our units, where we are in Saudi Arabia, of the programs, how they can reach, especially sometimes we found, like you, Ms. Hannah, and energetic new nurses, they love the field, but they don't know where to go. Not all of them, they have the facility or sponsorship to go outside, but where is the program in Saudi Arabia, and where we are actually, especially for us as a consultant neonatology, maybe we are away from that point. The same point for the scientific committee, I wish to see such topic every year to update us. Where can we guide our nurses to reach for the best experience? We are spending a time on rising up our fellows, training our resident, bringing a new machine, looking for the advance. But actually we ignore totally the nurses, and we leave them for their heads. So please guide us. Thank you.
This is really, thank you, Dr. Yahya, for the questions. Actually, this is making a challenge, especially for the new nurses who is coming in ICU, so how we can helping them. And also I'm having the challenge, some of the nurses, they are coming to the ICU, they are new graduated, and really they are so exciting to learn about the ICU. But For that, developing some programs, maybe in the future, we will have programs. I'm having actually in my mind some programs. It will be reached for that 3 months or 6 month training. Okay, some it will be like a hybrid. It will be lectures through the online, and some it will be workshop. But maybe this one it will be in the future. And for the training of the staff, I think it is depend on the every hospital centers. But from my side, I can be collaboration with that societies later on, and we can develop a nice, good teams. But we don't know, maybe in the future. But for that training of the staff, it is really depend on that centers. But I am having so many new staff. They are really talking with me. They want to learn. So I was doing from my time at sometimes at the PM, when I will go home, I will do that Zoom lectures. This is from my time. I'm teaching them about how to do this one and how to do this one. But it is actually need a team. It is need structures program. When they are consuming a time with me, they need a certificate that really they are attending. So all of these things, I think later in the future, maybe.
So it looks really a gap.
Yes, still it is a big gap, yeah.
So
Still
what
in
do you
the
think,
nurses,
Dr.
we are having a
Gibara,
lot of the gaps.
what's your experience in such? Our leaders again, if Dr. Mohammed
I think we
allow.
are running late out of the time.
Side talk.
Yeah, so we can just
Thank you
keep
very
it in the breaks. Thank you, Hana. Thank you very much. Thank you for the group and the great work. Thank you very much.
Thank you for all the speakers. Now, let's take a break for 20 minutes. And I would also like to invite everyone to join us to have a look at the posters. We have many abstracts today to be presented, very interesting studies. Please go around, have a look at it, and get to know people. After 20 minutes, we're going to start our second section with our international speaker, and then we'll have the closing ceremony. Can you hear me, Nancy?
Yep, I can hear you.
Great. So we're talking right now during the break, and it's on speaker. So we're just
Okay,
so
are you hearing me right now
yeah,
only, or?
I can hear you.
Okay.
Let's just double check if the screen works.
And can you see my slides without seeing my notes?
Just give us a second.
Yeah.
Yeah, we can see your slides and we don't see your notes, and we're just fine tuning it to make it fit the border.
Okay, and do you see me or just my slides?
Yes, we do.
Thank you, Dr. Nancy. We'll be starting, and you'll be noted for that.
So you'll just let me know when you're ready for me to start?
Yeah, absolutely.
Okay, thank you.
Good morning again. We will start, so kindly join us back into the hall. Please join us back into the hall. Okay, now we're starting our second and final session in our third day here. And it's an interesting session with one of our international speakers. And also to remind you all that we'll also be having a interesting workshop in the afternoon, a NRP difficult case simulation, also with leaders of the NRP and simulation in the region and also internationally. So without further ado, I'll just introduce now our moderator, Dr. Faiza Sulami, a consultant neonatologist well known in Mecca. Please join us and you can introduce our speaker.
Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome everybody. I think we reach the end of our journey for these last 3 days. Thank you very much for keeping with us and for your attendance. I would like to introduce the last speaker for the last session today. Ms. Nancy Cotto is a nurse practitioner, Neonatal Intensive Care Unit, London Health Science Centre, Ontario. She has over 20 years neonatal experience providing advanced medical management in level 3, level 2 in ICU, leading resuscitation, antenatal counseling, and quality improvement initiatives. Adjunct lecturer at Western University School of Medicine and Dentistry, certified NRB instructor, trainer, and she had interest in delivering education for nurses and junior doctors, and interest in family-centered care and quality improvement project. She will make a very enjoyable lecture about family-centered care in the NICU Canadian experience. Miss Nancy, you موجودة?
Thank you. Thank you very much for the introduction. And thank you for asking me to speak to you today about the Canadian perspectives on family integrated care and its importance in our NICU. I have no actual or potential conflict of interest in relation to this presentation to declare today. My objectives for this presentation are as follows. I'm going to speak to you about what are the differences between family-centered care versus family-integrated care. They're similar, but there are specific differences. We're going to talk about the goals of FI care. We're going to talk about the benefits of FI care. And we're going to talk about a model for implementing this practice into your NICUs. It's called the 4-pillar model. And next, we're going to talk about some strategies and what you can see when you've implemented this model in the NICU, and some of the challenges for implementing this model. It does take time, and there are some barriers along the way. So family-centered care in the NICU, infants are physically separated from their parents, and this very often has quite significant physical, psychological, and emotional health challenges for both parents and infants. So family-centered care is an approach to planning and delivering health care that encourages greater parental involvement at the bedside. Parents generally maintain a supportive role in the NICU. However, most of the care is still provided by the healthcare professionals. Versus FI care, which is an extension of the family-centered care philosophy. It's an actionable model by which parents are true partners in their infant's care. This model goes beyond merely allowing parents to be present and observe the care that their infant is receiving, but actually participate actively in the delivery of that care. The goal of FI care is really to facilitate this partnership and collaborative approach between parents, the NICU staff, which includes nurses, physicians, allied health professionals, that promote family, parent, and infant interactions and build on parent confidence throughout their engagement, support, and education. The philosophy of FI care is an evidence-based practice with research findings that have identified benefits of this model. One of the key studies that has influenced the FI care movement is this study here. It's the effectiveness of family integrated care in the neonatal intensive care units on infants and parents' outcomes. It was a multi-center, multi-international cluster randomized trial. And it identified some benefits for implementing this care. Some of those include faster weight gain, higher rates of breastfeeding at discharge, less nosocomial infections, shorter lengths of stay in hospital, and then these infants were actually less likely to be readmitted. And during this study, they looked at primarily infants greater than 33 weeks or slightly younger, however, needing very minimal to no ventilation support. So they were quite a stable population. And the study involved 26 NICU tertiary centers in Canada, Australia, as well as New Zealand. So there are also benefits not only to the patients and our neonates, but also to the parents. Parents reported less stress, so they had lower stress scores. They felt more confident and prepared to care for their infant at the time of discharge. And they developed a strong bond and felt connected to their infant instead of being a spectator on the outside. There's also benefits to staff. Staff felt more confident in the parent's ability to care for that infant after discharge from hospital. Staff reported satisfaction knowing that they facilitated that parent and infant bond. And staff were able to empower parents to advocate for their infant, not only in hospital, but post-discharge. So the model I'll discuss today is the 4-pillar model. There are various frameworks available for FI care. However, this is a common one used in Canada. This model was developed by O'Brien and her team in Toronto, Ontario, and was formalized in collaboration with Dr. Shu Li into what is now known as the FI Care Initiative. It was inspired by the human care model in Estonia, which is a unit where it's mother-infant 24-hour care unit, and the mother and the infant stay together within that unit. The 4-pillar model has been implemented across various NICUs in Canada, and it's endorsed by the evidence-based practice for improving quality, the EPIC program, and the Canadian Premature Babies Foundation. This 4-pillar model integrates parents as active partners in the care, and it includes the 4 key pillars. So staff education and support, which is essential, parent education and support, which is equally essential, And then a supportive NICU environment that embraces this model and has the physical space to utilize this model. Additionally, psychosocial support is key. So let's start off and talk about the staff education and support and how we can start to implement this components of this model. First, we need to ensure that the NICU staff understand what FICARE means. Why are we doing it? What are the benefits? What's in it for them? And next, education training for all staff and review the literature and the benefits. So making sure they understand, and that might involve some in-services or training for staff. And teaching staff how to actually engage and coach and mentor parents effectively. Next, parent education. So establishing a nurse-patient relationship where nurses act as coaches for the parents and teach them how to perform the simple daily caregiver activities. These are just some examples of some simple activities that we engage our families in. So helping with vital signs. So with our handling times, our clustered times, parents can take a temperature on the infant. They can help position their infant in an optimal position close to home. We tend to teach them back to sleep. Parents can change diapers. They can bathe their infant with RN there as support, but they can lead the process. They can help with feeding, or the nurse can teach them about bottle feeding, breastfeeding, provide lots of support. And even the infants that are still requiring NG tube feeds, we can teach the parents how to hold the syringe and let the feed go in while the nurse is there, present. So they're supporting that family to hold their baby while a feed may be going in through an NG. Learning infant cues and providing the appropriate comfort measures. So teaching parents what are the signs of stress in a neonate and how can we soothe them. Here are some images of a family in our NICU, and this family was very active in supporting their infant, and this was probably a few weeks before baby was getting ready to go home. Parents were taking temperatures. So you can see in the first image, the father's taking a temperature there. The second image, the mother's providing some mouth care with sterile water and a sterile swab, while the father's there trying to comfort baby and hold baby. And then the next image, mom's diapering. So this is their routine. So every 3 hours when baby's due to be fed, they'll come in, they'll help with vital signs and provide some of the care. Next, this is an image of one of our nurses mentoring a family, teaching them how to provide that care. And we can even do it on our smaller babies. This is a late preterm requiring some CPAP. So they're there with the handle times. The nurse is teaching them how to do the temperature, how to soothe baby. So next, parent education continued. There's other components as well. Having the parents actively participate during rounds in the morning. So we do bedside shared rounds with our multidisciplinary team. We do ask that the parents be present if they are available. And this really provides a shared meaning of what's going on with their child. It gives them feelings of control over the situation that is really out of their control. It's an opportunity to ask questions and address concerns. So we do encourage parents to think of some questions, write them down, and when we go to the bedside to do our multidisciplinary rounds, we have them present and they can ask their questions. We'll address their concerns and provide some relief to them if we can. Some of our parents are actually, who've been there quite some time, actually present their babies on rounds. So we'll go to the bedside and they'll introduce their baby's name, what their current gestational age is, their current weight, how much they gained, and then some of the simple changes in the past 24 hours. Of course, this is in collaboration with the RN beside them, but a lot of our parents who've been there for months get really good at this, and it's very impressive on how much they can participate. If they can't be at the bedside for whatever reasons, we do offer FaceTime, video chat, or even calling them and putting them on speakerphone so they can hear our rounds, our plan for the day, and ask any questions. We also provide NICU education sessions for parents, and this is led by members of the team, a variety of members, our nurse educators, our physiotherapists, discharge planners, any of our veteran parents. The veteran parents are families who previously had a baby in the NICU, and that baby has now graduated, and they still want to be involved in promoting parental interactions and helping to support the NICU. This is an example of one of our flyers for this month, actually, for our parent and caregiver classes. We actually provide this right in the NICU. We have a open seating area, like a small classroom. We let parents know that this is happening. We advertise this in the unit, and we have various sessions. So this month, we're talking about car seat education, discharge planning. What does that look like? What are we going to teach you? What can you expect? And then safe sleep, some safe sleep practices. They're very simple presentations, often led by our staff or veteran parents. And they're short. We often have snacks there available, coffee to entice families to come. And actually, our turnout is usually pretty good. Another key component is having a supportive NICU environment. And sometimes this can be a challenge. You need to have physical space for families to be at the bedside all day, or for as long as they would like, and a place for families to stay near their infant. So in our hospital unit, we do have an area where parents, a kitchenette area, they can bring their lunch from home, put it in a fridge there, stay at the bedside with their infant, take a break, go into the kitchenette, go to the kitchenette, eat. And we also have a lounging area that they can go to. We also have rooms where parents can actually stay overnight and provide the care. There's an RN assigned to that infant, but the parents stay and lead the care. And usually we offer this when the infants are closer to discharge. No restrictions on our visiting hours. Parents are allowed to come in whenever they like. Breastfeeding pumps. If moms wish to breastfeed, we do provide pumps and lactation consultants to support them with the breastfeeding. We also have enough pumps that we can have one at the bedside when moms are there. We have privacy curtains so they can pump beside their infant. We have whiteboards in the infants' rooms where parents can communicate any questions, any thoughts. They can write the newest weight, things that their baby might like, not like. We also have accommodations on hospital property for families who are out of town. Because we're a tertiary center for our referral area, sometimes we have parents that are from hours away coming to be with their infant. So we actually have on our property accommodations, hotel style, that they can stay in. We have recliner chairs for our parents to provide kangaroo care, which is skin-to-skin holding, which we are strong advocates for all our babies, whether they're ventilated or not. As long as they're hemodynamically stable, we try to encourage that. So you can see in this image, this is actually a father in the NICU doing skin-to-skin care with his preterm infant who's ventilated. Now, this infant was hemodynamically stable. And to take baby out, the nurse, the RTs kind of collaborate with the parents, what time would work. And usually when we take a baby who's a little smaller or ventilated, we suggest that parents stay for a few hours and hold. And usually that's not a problem. Parents love doing this. And we often find that the babies actually really enjoy the kangaroo care, and their heart rates usually stabilize. They have less desaturations often, and sometimes their O2 needs will even drop. Again, this isn't for every infant, but those stable babies, this works really well. This is another image of one of our rooms. We call it our care by parent room, where When babies are getting close to discharge, the parents can actually stay in the room and have an RN just outside the room, and they provide the care. The couch is a pull-out bed, so parents can stay overnight. There's a lounging chair where you can see mom providing some kangaroo care there, and dad's supporting her. And they can come and go as they like and ask for any assistance from the nurse. And the nurse will check in with the vital signs as well, but they will lead it and the nurse will support. Another thing that's really important in this model is psychological support. So supporting families in the NICU. We have 4 social workers that are specific to the NICU who check in with our families and make sure they don't have any questions, concerns, they're coping okay, and provide them with a lot of resources that we have available, not only in the hospital, but in the community. Our veteran parents, the ex-graduate parents, are often involved as advisors and will sometimes touch base with families. Mental health care workers is ideal to have available if we are having any challenges with any families. We encourage parent journaling because they're at the bedside for long periods of time, and writing down questions and concerns so we can address them. Peer-to-peer support, so parents getting together, oftentimes these weekly teaching sessions with families, parents will get to know each other and they become supports for each other. We do have music therapy, which is kind of an interesting concept, but is pretty amazing. Parents love it. We also have newer addition is art therapy, which also involves the parents. And then we also have child life specialists for siblings of parents, babies that are in the NICU and are unwell. The children don't really understand what's going on, so these child life specialists can connect with them and help them cope. This is an image of our music therapist, actually, while mom's providing kangaroo care and holding her infant. She might set up appointments to come in once or twice a week. She has different approaches. She'll play music, calming music, sing. Parents really love it, and the babies seem very stable and usually fall asleep through it all. Our parent advisor group is actively participating in a lot of our projects. So they meet with families as necessary. We develop new handouts, brochures for our families. We often will get them involved to review it to ensure, is this content what our parents are wanting? Does it make sense to them? Is it simple, in simple terms that they can understand? So they're very active in that role. And we have a FICARE committee in our unit, which includes nurses, nurse practitioners, physicians, clinical educators, physiotherapists, parent advisors, as well as our social workers. So what are the barriers of implementing this model? Well, there's quite a few, and it's not perfect, and it takes time to implement. And sometimes you can only implement components of this model at a time. But the challenges we found and the literature has reported is really lack of physical unit space is a barrier. Lack of hospital financial resources to implement what we need to make this model successful. Attitudes, personal beliefs, and mindset of staff. It's a big change in care philosophy, so sometimes it takes time to adapt. And then cultural expectations that might conflict with what the FICARE principles stand for. Inconsistency between healthcare providers is a challenge. It confuses parents. And then knowledge gaps regarding the benefits and the philosophy of FICARE, which goes back to the really important piece about staff education. A more recent article found that facilitators and barriers to the practice of neonatal family integrated care from the perspective of the healthcare professionals. They did a systematic review and did some qualitative data and looked at themes, and those were what we just discussed as barriers, was in line with those. Canadian educational resources that are available, open online. There's a FICARE toolkit resources that you can access at any time. We also have the Canadian Premature Babies Foundation, which has a lot of excellent information, handouts, and things that you can access and are great resources for our families. And this is just one of our families that graduated, and their child is a 25 weeker and is done well, and this family still becomes involved in our unit and is a veteran family. Thank you for listening, and there's some references if you're interested.
Thank you, Ms. Nancy, for this enjoyable lecture. هو إيش بقى اختفت؟ طيب, any questions? دكتور حكم.
I think this is.
It's working. We can hear you.
Yeah. Thank you, Nancy, for this presentation. And as we get so busy with this sick newborns, many times we forgot these essential issues that should, continue with them all their life, the family and the involvement of the family. For the extended family, like, the siblings and the grandparents, what is your visitation, policy for that? Are they allowed to visit, to enter? Is there any problem with the infection control team? Are they saying, no need to do that? What do you do usually?
Thank you for the question. Yes, our visiting policy is fairly liberal. We do recommend only 2 parents at a bedside at a time or support providers. So if the parents would like a grandparent to come, a older sibling to come, they can come into the bedside as long as they're approved by the family, the parent. But only 2 at the bedside. Siblings can come in outside our RSV season. We don't allow younger siblings to come into the unit just for the risk of transmission of RSV. And all children need to be vaccinated to come into our NICU. But we're quite open with our visiting as long as everybody's well and has been vaccinated. And we're actually big advocates for the hand washing, and actually having the parents at the bedside, they're actually very strong advocates, and they're the best at hand washing usually once we teach them.
Any questions? Okay. Thank you so much, Nancy, for making it today. We learned a lot, and it's nice to see familiar faces again. I just have a question about any possible cultural differences. I know that the population in Western Ontario is becoming more diverse, and you're seeing a lot of people from Middle Eastern descent. I was wondering, in your personal experience, have you seen preferences or differences between families coming from the Middle East versus, Canadians? For example, because in my perception is that Middle Easterns may not be so familiar with the concept of family care, and they put the onus on the healthcare provider to take over everything. And there might be a need for more empowerment. I just want to hear your perspective and your experience about this.
Yes, thank you for the question. We do see a lot of Middle Eastern families and multicultural families coming to the NICU. And I think the big piece is the education and the understanding of the benefits that can be provided to these infants. Many of our Middle Eastern families that do come, once they're educated on the practices of family integrated care, very often are very engaged in the process and are very open to holding and being at the bedside and providing the care and actually appreciate it. And the infants do quite well. So we actually have a really positive response.
Any other questions? Yes.
Thank you. My question is going to be very costly to build up a family center unit compared to our usual unit. Is it cost effective? I mean, is it going to affect our mortality, our morbidity of our tiny baby if you spend all this money, especially from the nursing? You need one-to-one nurses. Thank you.
From a cost perspective, in the long term, there is potential for benefit, and there's literature out there to support the benefits. Shorter lengths of hospital stay, less readmissions, parents feeling more confident in providing the care when they go home, so less appointments coming back. So from that perspective, financially, you know, do I have the specific data to say that we've saved this much money since we implemented it? I don't have that, but we do see earlier discharges when parents are very engaged and feel comfortable providing the care. As far as, sorry, what was the second part of your question?
Does it affect the long-term outcomes of this baby, the neurodevelopmental outcome for such a preterm baby?
I don't have that data on me, but they tend to, like I said, go home sooner. Parents tend to be very engaged in the care and are more compliant to bring to follow-up and coming to hospital.
Any more questions? I think this is the last question we can take.
Allow me just one more question, I'm sorry. It's very common in many centers in Saudi Arabia to have limited visiting hours, especially for the father. And it's usually 24/7 for moms, but there's some limitations for the father for usual visiting hours. And I was wondering, what do you think about that? Is the presence of the father actually makes a difference or not? And I would also like to ask you about, especially I remember during COVID times, there were a little bit limited access for the parents, which kind of reminds me of our usual state that we have in Saudi Arabia. How did you see the effect on the babies during that time? Because that will kind of, I can extrapolate what's going on in Saudi Arabia based on that.
Okay. We do strongly encourage fathers to be an active participant in the care as well. It's supportive to the mother, and you know, they're both equally important, we feel, in the care of the infant. So, you know, two people asking questions, two people at the bedside, and you know, you can't always be there together, but often our families will take turns. So dad might come for a couple hours, mom might take a break, and then they are continuously provided with knowledge and updates on their infant, which is beneficial. So from that perspective, we strongly encourage both parents to come as much as they would like, or as much as they can. As far as going back to the COVID times when we had limited visitors, it was challenging. And you know, we actually saw an increase in kind of workload for some of the for the nurses as well. Because when the parents can't be there all the time, they do provide, once they're competent and they feel comfortable, they provide a lot of the bedside care with the support of the RN. So our babies aren't actually, when we have a 5-care model like this, it doesn't really actually make our ratios more stringent. We actually can, you know, still care the same as we would. We have 2 or 3 babies with one nurse. It doesn't have to be one-to-one care. Once babies feel confident, or parents feel confident providing the care, they actually can take over some of the initial vital signs, changing the diaper, doing that, and then review with the nurse. So it's actually a little bit less work for the nurse. So, you know, when we didn't have the parents in there as much during the COVID times, we actually missed that component. And there was more meetings having to be had because they couldn't be present necessarily at rounds all the time. So it was more phone calls. Whereas when they're at the bedside, we communicate right away. We provide them with the updates. They ask their questions. It's very collaborative, and in the long run, it actually helps the medical team as well.
Okay, thank you very much. And I think this is our last session. We will wrap up. Thank you, Nancy, for your enjoyable lecture and your answers for the question. Thank you.
Thank you very much.
Thank you very much all for attending. It's been wonderful seeing you all for 3 consecutive days and seeing people that we know and getting to know more people. It has been a full and rich scientific conference, full of content, insightful discussions with a lot of collaboration. From the first session till this morning, there was a lot of engagement and participation that was truly inspiring for all of us. It wasn't really about presentations, it was really about sharing experiences and getting to know people and networking during this conference. And it is nice to see neonatologists, healthcare providers, RTs, RNs, physiotherapists, everybody coming in with one single goal of improving our outcomes for our smallest baby. And before we bring this wonderful day and conference to closure, it's now time to celebrate the success of this conference and your presence with us. We would like just to ask our friends in audiovisual to start a short video that recaps all of this conference. If you can start it now. Thank you very much, and I would like to invite the President of the Saudi Neonatal Society and also the Vice President, Dr. Ibrahim Al-Hifzi and Professor Abdurrahman Al-Nimri. Now we're, and Dr. Al-Qattan بعد, and also if Dr. Amjad is around, the organizing committee would like to see. Yeah. Those are the people behind all of the success that we had, and we need now to recognize the winners of the abstract competition. So for just to remind us of the prizes and the winners, I think it's more, it's non-material with the win. I think just the concept of being the winner is just very fulfilling. The first place will take the third place. Okay, we'll start with the third place. So third place would be Dr. Dalal Ashmawi, risk factors associated with loss of follow-up in newborns and failed hearing experience from the Saudi Tertiary Center. Congratulations. to get everybody together and make this conference happen without our help from our sponsors, the companies and the societies that helped us collaborate. Thank you for our platinum sponsor, Easy Well, Easy Lab. Also, I would like to call our bond sponsors, Neonatology, AstraZeneca, and next, thank you also to Algil Company. Also, I'd like to thank the companies that helped us with the exhibitors. The exhibitors, actually, the ABV. Okay. And also the next company, Idea. Last but not least, Lion Pharmaceutical. And also, we would like to extend our appreciation for our supporting societies, the Saudi Society for Disabled Children.
تستمر الجمعية في تقديم ما ينفع الأطباء وجميع الكادر الصحي وما ينفع مرضانا على مستوى الوطن الإيراني وجميع المحتاجين الذين نعتز بخدمتهم. نسأل الله سبحانه وتعالى التوفيق.
أنا كلمة حافظها من كم سنة بقولها مرة ثانية، اسمع فيها كواكب. شكرا للجميع، من أجلكم تعبنا ولأجلكم غنينا. نتمنى أن يكون غنانا في قلوبكم وفي عقولكم. نستمر بهذا المشوار ونوعدكم بالاستمرارية. والبارح البورد قرر أن المؤتمر القادم لسنة 2026 حيكون في أبريل. So put it in your calendar. شكرا للجميع.
نستأذن الضيوف الكرام، صورة جماعية للجميع لو سمحتم تشاركونا على الستيج جميعا. أستاذ مصطفى، أستاذ وليد، الجميع.